My name is George Kim. I'm a gastrointestinal oncologist from Jacksonville, Florida. And today we're going to talk about a trial that we did through the Mayo Clinic Network, looking at the utility of the Oncotype DX in making decisions for stage 2 colon cancer patients. The trial was a prospective, multi-center study that enrolled 221 patients with stage 2A or T3N0 colon cancer. This was across 17 academic and community sites by 105 oncologists. It's important to know that most of the patients were from the community, and the academic sites were really the 3 Mayo sites. The oncologists identified the patients, and again, they had to have T3N0 tumors. They would then consent them and perform a questionnaire or fill out a questionnaire. Thereafter, the Oncotype DX testing was done, as was mismatch repair testing. And these results then returned to the clinic in the next follow-up appointment with the oncologist and the patient, and dependent on the results of the recurrence score and the MMR status, decisions were made based on these findings. For example, if patients did have mismatch repair deficiency as part of the recommendations from the NCCN, they were not treated and simply observed. So the patients that were proficient and had the recurrence score returned, based on these results, treatment decisions were ultimately finalized. The primary analysis focused on patients, again, with MMR proficient tumors. Patient characteristics and tumor characteristics, as everyone knows, we do have set criteria, high-risk patients for whom it is recommended they undergo treatment. Unfortunately, these are not well accepted and they leave a lot of gray area. Just to review, these are the differentiation of the tumor, lymphovascular invasion, obstruction, perforation, and the number of lymph nodes that are evaluated. So looking at the patient and tumor characteristics within the study, we see that the mean age was right around 63. There were more females than males in the trial. There was mainly Caucasian patients in the study. Performance status was 0 and 1, with the majority being 0, having recovered from surgery. Tumor grade was high or poorly differentiated in 10.7% of patients. And most patients obviously had adenocarcinoma, 94%. The surgeons did a wonderful job, as did the pathologist, in evaluating lymph nodes, with 91% having greater than 12 lymph nodes assessed, and lymphovascular as well as vascular invasion are seen on the slide. So again, the design of this study was to make decisions in regards to whether treatment should be given or patients should undergo observation. And then the Oncotype DX colon assay was submitted and the results available, and another visit with the patient and the oncologist occurred, and final decisions were made. So in the slide, we see that 55% of decisions in regards to observation or treatment were unchanged. But importantly, 33% of patients, the recommendations for treatment were reduced based on a lower or more favorable recurrence score. And in 11.3% of patients, or 16 individuals, more treatment was recommended based on a high recurrence score and greater concerns for recurrence. So this overall led to a 45% change in the initial decisions that were made for patients based on the Oncotype DX colon results. We see in the next slide that we see some of the detail in regards to the overall changes. So for example, before the assay result, 48% of patients were to be observed and not undergo treatment, and this increased to 70%. In terms of actual treatment, 24% were to be given 5-FU monotherapy and based on a more favorable recurrence score, this was reduced to 13. And then finally, very importantly, because of the side effects and the potential long-term consequences of oxaliplatin in terms of neuropathy, and finally, and importantly, in the 5-FU oxaliplatin group, reductions in the patients that would be administered this agent were made. And this is very important when we think about the long-term potential consequences of oxaliplatin, especially in regards to the neuropathy that is commonly observed and how that impacts quality of life. So overall recommendations for chemotherapy were reduced by 22%, and importantly, the recommendations for FOLFOX and the use of oxaliplatin were reduced by 11%. And again, the number of patients that did not undergo chemotherapy and were observed was increased to 70%. What are the conclusions from this very straightforward analysis? Well, they're very provocative and they are potentially groundbreaking. This is the first prospective study to assess the role of a quantitative recurrence score and how it impacts decision making for those patients that are stage 2A mismatch repair proficient. As we all know, we tend to treat, or it's recommended that we treat the T4 patients, the microsatellite instability patients, or the MMR deficient patients. We are going to observe, but the majority of patients are this group of T3N0 MMR proficient, and now we have a test that is quantitative and allows us to make these decisions. And we can see in real world patients in the community setting in the majority of instances that this has very important influence and impact on these decisions. The treatment recommendations overall changed 45% for these patients, and the direction of changes were concordant with the recurrence score results, meaning there was a net change and 22% of patients had a decrease in their chemotherapy recommendations based on a more favorable score. I want to give conclusions in regards to a clinical utility study that we performed employing the Oncotype DX colon assay for stage 2 colon cancer patients. This was a prospective, multi-center study in both academic and community sites. The design of the study was very straightforward. Patients met with their physician after being diagnosed with stage 2 colon cancer, came up with some form of decision in regards to treatment or observation. The Oncotype test was then submitted and the results available, and the patient and the physician met again, and in that instance, 45% of the pre-test decisions were changed. 33% had treatment reductions, and 11% had treatment intensification based on concerns of unfavorable or poor prognosis scores. Ultimately, this study demonstrates the clinical utility of the Oncotype DX test, and in real world practicing oncologists and patients, this is critical to have available to us, as there are limitations in the present manner that we make these decisions. This will impact economics and the quality of life of patients overall, and that's the importance of this study.